With this, I would like to ask people for any final thoughts about all the different things that we discussed. So, Peter, for you, any take-home messages you'd like us to take with?
One aspect which might be stressed and which we haven't been talking about so much is the relevance of side effects. Side effects is something we are afraid of, and the patient is afraid of, and it results in a stop of treatment. However, in recent years we have learned that in TKI related side effects, there is also, let's say, a positive option in that all these side effects are related to better outcome. So patients who, for example, develop hand-foot skin reaction do benefit more from therapy. What does that mean? It means that we have a way to discriminate those responding better than others, and it tells us that it's very relevant to keep patients on track. We have to play around much more with our TKIs than we thought in the past. In the beginning, we felt either there's a full dose or nothing, and we should not be flexible about that because patient will be in the end undertreated, tumor will become resistant. It's not the case. We can go up and down and adjust it according to the needs of our patients. And I think that is very relevant, and particularly when we now in the future will talk about combinations, it's all about toxicity. And the only way to guide a patient through therapy is that you adapt therapy according to the patient's needs. And that needs a fine understanding of side effects and a tapering or an adaptation of the dosing. That is, for me and also for the audience, a very relevant aspect which has been overlooked in the past and will play a major role in the future.
I totally agree. If anything, I'm glad you bring this up because obviously checkpoint inhibitors, same like TKIs, have side effects. Thankfully, we don't see probably too many side effects with the checkpoint inhibitors, but they can happen. And we have to really be very vigilant in regard not only to TKIs, but also to checkpoint inhibitors as well. Riyad, any final thoughts?
Yeah, just a couple of things. One is, and Peter alluded to this, I think we have to continue to think about combination therapies. The reality is everybody gets a combination. We have to figure out what is the optimal way, and particularly if you have early or intermediate disease, how can you maximize that without having the issue of side effects and start systemic therapies early. The other thing I would say is response matters. I think it's something at the individual patient level. This is something that matters to patients, it matters to physicians. It's probably the most talked about issue when in follow-up clinic, and frankly is what is causing a lot of excitement in the HCC field, these responses that people are seeing. I think overall survival as an endpoint is a clear one for very advanced disease. It's much more challenging to perform clinical trials in earlier disease and intermediate disease, and I think investigators and thought leaders have to really figure out endpoints that are relevant that will move the field forward, that will get incorporated into guidelines, that will be enough for scientists and physicians to act on that data. I think is very important. And ultimately for me, as an interventional radiologist, I deal with a lot of different conditions. HCC continues after 15 years to be the most exciting one in my opinion. Even with a 10-year lull of the sorafenib until now, it's still the most exciting field that I work with, and I'm always sort of proud to be in that tumor board.
Well, honored to have you as well. And if anything, the points that Riyad are mentioning is number one is we still definitely have challenge in regard to the endpoints. We all agree that response rates definitely actually, as we discussed it, has evolved quite a bit in regard to that disease. And not only the response, but also the extent of response or how long the response will be. But on the other hand, we put this in perspective in regard to the intent to treat that we brought up a little bit, especially with the atezolizumab. And number three is the point about the criticality of the overall survival. Whenever something happened to the patient, whatever happened to the patient on a certain intervention, it is actually part of that patient care. And as such, the overall survival has quite a bit of still critical importance in that regard. But I like very much what Riyad said. If anything, the most important great news is actually for the patients. We have a lot of opportunities for patients, and really at least now we can offer things that hopefully will extend life and hopefully, of course, looking for a cure. Amit, final thoughts.
Yeah, so I have two closing thoughts. The first is that we've seen a lot of advancement in terms of local regional therapy and systemic therapy, but I think at the end of the day, it goes back to where we started, that really the best survival is if you're found at an early stage. So it's important, we know the at-risk population, it's important that we really promote HCC surveillance, find these patients at an early stage, and when they are found at an early stage, to refer them for curative therapies. I mean, at the end of the day, the best survival is with resection, transplantation, and local ablation. And then the second point is that you've seen that with all these advances, HCC, it's exciting, but it's increasingly complex. The BCLC makes this seem like you can just follow the lines down and say that this is the therapy, but these lines are becoming much more blurred. You're seeing much more transitions between therapies, much more combination therapies, and the difference is that these therapies are all delivered by different providers. And there are increasing data showing that multidisciplinary care in expert centers, you've already heard this several times, that a radioembolization is not a radioembolization. Chemoembolization is not a chemoembolization. And so it's really important that patients are referred in to get multidisciplinary care in high volume expert centers whenever possible.
No, that's very well nicely said, and especially the second point that Amit mentioned. As we all know, and maybe some of us don't, but October every year is the Liver Cancer Awareness Month. And if anything, it's very important that we kind of, present that discussion and that effort that we put together over here to all patients and all caring physicians for patients with HCC, as we really look forward for all those new advances that hopefully will improve outcome. This really brings a very important point that really the screening and prevention are critical, as Amit referred to. And if a patient has hepatitis B, has hepatitis C, or even any concern or potential for a risk factor from or for developing HCC, they better be checked by their doctors and make sure they are followed on the already well proven and well documented screening approaches and systems that are in place. Very, very critical. With this said, I would like to thank you all for joining us for the discussion. This was terrific. On behalf of the panel, we thank you very much for joining us, and we hope you find this OncLive at Peer Exchange to be useful and informative.